So we are starting this another edition of clinico radiological meet at Max Hospital. So today topic is about extensor tendon injuries. Extensor tendon injuries. Doctor, the program agenda will be like this. Dr. Gaurav will talk about something introduction in which anatomy and zones he will discuss. Then we'll discuss few cases about extensor tendon injuries, what happens, what deformity occurs when injury is at the different level or different zones, what are the things on what deformities occur. So over to you, Dr. Gaurav. You want to share your screen? You can share your screen.
Yeah. Good evening, everyone. So please allow me to share my screen, sir.
Mm. Can you share your screen?
No, sir.
That possible. Can you do it now?
Yes, sir. Now I can. Can everyone see my screen?
Yeah, can you make
Yeah.
it to presentation mode? Yeah, now it's fine.
Yeah, it's on the slideshow mode. Everybody can see that?
Yes, yes.
So shall we start?
Yes, Gaurav, we can start. Yes.
Right, sir. So good evening, everyone. Today we'll be talking about the clinical radiological discussion for the extensor tendon injuries. So we will be starting with a slight introduction about the extensor tendons. We'll be talking briefly about the anatomy and the placement of the extensor tendons in the hand, especially at the wrist joint and beyond. So there are certain salient features about the extensor tendons which differentiate them from the other tendons of the body, especially the flexor tendons, which we are more concerned about. Mostly these extensor tendons get ignored in view of the flexor tendons and their intricacies, but definitely extensor tendons are uh, slightly different from other tendons in view of, firstly, they are superficially placed with a very minimal soft tissue coverage. Because of that, they are very prone to injuries as compared to the flexor tendons. Secondly, like we all know, the flexor tendons are um, round. These extensor tendons are thin and flat and are ribbon like, which make them injury prone also. And secondly, very difficult to repair the extensor tendons, because all the techniques which we study, which we practice, are mostly suitable for the round tendons, but there are very few techniques which we can use for the thin and flat tendons. Those are very different from the routine techniques of the tendon repairs. Thirdly, they lack the true synovial sheet, especially beyond the wrist joint, as you can see in the figure also, which is available with the flexor tendons. So it makes them very prone to adhesion post repair, especially during the rehabilitation period. And the very special point about extensor tendons is the presence of juncture tendinum, which are the intertendinous basically these are the connections, intertendinous connections, which are present mostly over the dorsum of the metacarpal region, in which the tendons of the different fingers are you know joined to each other, causing they help each other in the movement also. And because of these juncture tendinum, uh, there are few instances wherein the injuries of these tendons, especially at this point, may go even unnoticed, because even after the injury of one tendon, the movement can be done because of these interconnection with the help of the other tendons. And another thing about these extensor tendons is they get inserted in the form of extensor hood, or what we can call as dorsal digital expansion, which is formed at the level of MCP joint, and then they get separated into the central slip and lateral bands, and they have got segmental insertions, unlike the flexor tendons which have got insertion at a particular point or a particular anatomical region. These have got segmental insertion in which they beautifully form a dorsal digital expansion, in which they get in support from the introitiae also, and from the EDCs and from the lumbricals, thus forming a complicated, we can say, like insertion pattern, which is very helpful for the intrinsic functions of the fingers. Anything Akram sir or Vikas sir wants to add to it?
See, we'll talk about zones. We didn't talk about zones.
Yeah, sir.
Zones are
Yeah, sir. We will. There are two types of zones of the extensor tendon. First is the intercompartmental fascias are there at the level of the extensor retinaculum, which divide the extensor tendon anatomically into the 6 zones. Basically, six. I will not call those as zones. We will call those as like segments. In first zone we have APL and EPB. In second we have ECRL and ECRB.
Okay.
In third we the second and the third are
there's
divided.
some confusion. There's some confusion.
Sir,
So these are the compartments. Sorry, I'm
these
sorry
are the
to interrupt.
compartments, right, sir? The correct
These
word.
are the compartment which are
Yes.
at the dorsum of the wrist. Zones are like divided
Zones
into
are
the
these are the zones in which we divide the injury of the extensor tendon. We classify the injury of the extensor tendon according to the zones. They have got. We typically talk about 8 zones of the extensor tendon injury, in which the odd numbered zones are over the region of the joints. Like zone 1 is over the DIP, zone 3 is over proximal interphalangeal joint, zone 5 is over metacarpophalangeal joint, and zone 7 is over the extensor retinaculum or the wrist joint. And in between them are the zones, zone 2, zone 4, zone 6 and zone 8. Zone 8 basically refers to the muscle part in the distal forearm. This is what you are referring to, sir?
Yeah. I think there's
So
enough.
okay.
Let's go on to cases first. If Akram, you want to add anything?
So I just wanted to
Amit,
add,
you want to add
this
anything?
classification is a guideline. It helps in guiding the level of injury, and treatment is dependent upon the level of the zone of injury. So there
Yes,
is
sir.
horizontal classification and vertical separation. So vertically, we divide them into this zone system.
Right, sir.
So when in imaging, we don't give the don't write that this is that zone, but definitely we talk of the exact level where the injury has happened, and that is definitely corresponding.
Amit, there are two things. A, where the injury is the primary injury, say if it is at the PIP level, and where the tendon is lying. The zone of injury is where the injury has occurred, primary injured, where the primary separation has occurred.
Okay. Okay.
And wherever it is lying, it is not important. Yes, it is important radiologically, it is important physically also. But in classification, we divide upon, discuss amongst the where the injury level is.
Okay, so the zone is the level where the injury has happened, irrespective of the ends where the
Yeah,
tendon
yeah.
is lying. Okay.
Because sir, the zone will determine whether we will get the distal segments also, how many distal segments we will be getting, and how our management will change accordingly. The zones are important surgically to determine the management of the extensor tendon repair, right, sir?
Yeah, I think enough because according to the zones, the deformity will change, clinical presentation will change.
Yes.
Now, what we'll first go through the cases. Gaurav, are we ready with the first case? I think you
Yeah, sure,
keep
sir.
on showing. Yeah. Because, yeah, case one.
So our first case for tonight is a 40-year-old male which has got a history of trauma 1 week back and presented to us with complaint over pain over right little finger with difficulty in movements. So when we examined the patient, there was flexion at the proximal interphalangeal joint with no active extension at PIP. So I'll just go ahead and will request the radiological team for discussing the pre-op radiology of the same patient.
Good evening, everyone. I'm Dr. Ira. So on ultrasound, we found that there was diffuse thickening and scarring. I'll just use my pointer. Can you see?
You can annotate
Yes, sir.
at the region, like put the annotation and then you can show that there.
Yes, sir. So we can see that there is diffuse thickening and scarring of the extensor tendon central slip at the attachment site of the at the base of middle phalanx. And this length of thickening was approximately 1.5 centimeter. And on dynamic imaging, we could see that there was normal gliding of the tendon seen over the proximal interphalangeal joint.
Yeah, so there is definitely we can see in this is the what we see, this is the proximal interphalangeal joint, and
Okay, sir.
we are able to see this is the extensor tendon central slip, and if you see there is all this is definitely not normal, it is all dark and there is quite diffuse thickening, and there is, we can also see there is this flexion deformity of the PIP joint. So from this only image only we can see that there is definitely some injury to the extensor mechanism, and as there is clumping of the fibers proximally and thinning of the fiber at the attachment site to the base of the middle phalanx, so there's definitely this implies that is a high grade partial tear, or maybe it may be a complete tear based on the duration of the injury. There can be a whole lot of scarring which is happening in this region. So this is what we can, yeah.
So this patient, if they present fresh, we can actually very well differentiate radiologically also on ultrasound that we can see a gap between the
Yes.
cut ends. Okay. How do we differentiate radiologically if it is an old injury, whether it has healed or not, if there is no deformity or it is a post-surgical case?
So if it is a post-surgical case, so definitely we will see, we cannot see an absolutely normal tendon. There will be some sort of thickening. We will be able to see the sutures or whatever the material has been used. But the continuity of the fiber will be maintained. And when we do the dynamic movement, we can see that along with the bone movement, the tendon is moving. So that is one of the signs of continuity.
Okay. And is there a time?
Amit,
Sir, Boldi. Please continue, sir.
Amit, there's a lot of confusion in imaging about continuity because scar is also
Yeah. No. So in case of scar, what will happen? We won't see the normal appearing tendon, which will look like a flat linear structure. In case of scarring, there will be globular soft tissue in the region of the tear, which we call it as a scar.
So why I'm saying this, because one or two cases, high grade partial and total
Complete.
tear, it becomes a little bit difficult when you're saying high grade partial. Patient thinks that it is a partial injury. Here the surgeon, because it is a near complete, and plus there is a deformity, and you see that normal fibers are not going across the in the
Joint.
ultrasound, the
Yeah.
fiber pattern or collagen pattern is different.
Right, sir.
So there the confusion comes because people think that it has healed, but it is a scar, and scar is not as strong and it stretches with the time and causes more deformity. So we'll discuss about deformity later, but so can you show us how does the scar and tendon we can differentiate on ultrasound in this? No.
So here also, sir, if I show you this thing which you are seeing, this is all scar, and maybe this part is also a scar tissue. Whereas if you see this fiber here, so I feel that because this is quite bright and this is looking to be a thin flat structure, so I feel that some fiber may be continuous here, but otherwise there is like all lot of most
Yeah.
of the fiber are torn and they are retracted and there is scarring there. So when we talk of some high grade partial versus complete, so that is a limitation I feel in the imaging wise, because some fibers which are not like completely retracted and they're lying nearby the bone, we may see them that there is feel that there is continuity. But when we do a dynamic study, we can see the gap between the fiber and the bone.
So the
that-
fibrous band doesn't slide.
So the fibrous band, if there is a fibrosis and the fibrosis is reaching the bone, so still we may not demonstrate that gap. So that is where the limitation is.
So do you
Yeah,
think
that is
MRI?
where the clinical finding come.
Yes, sir.
Because what happens, scar stretches and the tendon, it is not as strong as the collagen of the tendon. So it stretches and the deformity remains. So this is where the like pure imaging and clinical finding, we should differentiate. If there's a deformity occurring, flexion deformity, especially in such cases, there will be initially flexion deformity, or you can say extensor lag at the PIP joint, and long standing cases, they can turn into Butner also when there's a subluxation of the lateral band. So
Right,
we'll
sir.
talk about it. Yeah. So
even
what is the next? Yeah.
Yeah, so
Sorry.
even is this image, sir, just go back. So even in this image in the ultrasound, so we can see that there is the flexion deformity at the PIP. So that itself says that there is definitely the lag, and it must be definitely a very high.
But this we cannot say because it can be that patient has kept it in the flexion. This is the attitude
This
also.
could be a polar plate contracture also in terms of.
Okay, so that is the thing. But when we do the imaging like ultrasound, we try to flex and extend it to see
See, that is why we want the dynamic. Dynamic should also be talked about. Dynamic study like tendon gliding, etc. Whenever we are reporting, because most of the time in the reporting, dynamic things are not mentioned.
Okay, but we definitely do in all the cases.
I understand, but what happens, see, that is the use of this meeting, that we can talk to each other. But when we are reading only reports, then many times these things are missed out on reports. This is for the residents and junior, for your
Right,
fellows
right.
and other staff. Like, if you're doing dynamic, just mention one or two lines of the significance, like it is gliding, or there's a
Gap formation.
Gap, yeah. Okay,
and
fine.
measure the gap. Many times it helps us by measuring the gap. So Butner deformity, as we were talking, whenever there's a central slip injury, what happens, there's a flexion deformity, or you can say extensor lag, and because long standing, the lateral bands, they subluxate bolowards. So now they're acting as a force of flexion because the vector changes, so it causes lateral band of the extensor tendon becomes a flexing force at the PIP joint, and because tension is increased, the finger is, you're trying to get the extension of the finger, lateral band, they join to form a terminal slip, and it causes hyperextension at the DIP joint. So finally, what happens, that there is a Putner deformity in long-standing cases. Any questions regarding this slide?
Sir, I just wanted to ask if there was a high grade partial, if there was a complete tear. So when we do the dynamic imaging, so we should see there is widening in the proximal interphalangeal joint, right?
No,
No, joint
joint
will
is
not.
stable. Joint is stable.
So when
Joint,
we,
joint will open if there is a capsular injury with it also, or collateral
Ligament or
also.
capsule. Ligament injury, because joint is concentric. There's a convex and concave surfaces. So joint is going to glide. So that is why the deformity occurs. The gap will be occurring between the bone and the tendon.
Yeah. So
It is not a hinge joint. It is just sliding, like it is glides over the phalanx, glides over the head of the proximal phalanx.
Yeah.
so on dynamic,
Base
we
of
can differentiate between complete and partial.
No, so no, Dr. Ira. So when we do suppose if this is the complete tear in this image, if we see, and if we do a flexion, so the movement in the PIP that will be normal. But as you do flexion, the gap between the bone and the torn tendon end that will increase, and you won't see any fiber in between. That's what.
And there will be no movement at the central slip.
Yeah.
Okay, got it. Thank you, sir.
Okay, Gaurav, next slide. Can we change the slide?
Yeah, then we took the patient to the OT, and intraoperatively, when we opened it up and we saw that there was complete rupture of the central slip of the little finger. So here we can see the torn central slip. This is the close-up image of the same. So here we can appreciate these are the lateral bands, and the point where the blade is pointing up is the footprint of the central slip where it was supposed to be attached. It got detached from its insertion. So as we were talking about the zones, the zone of the injury determines what will be the operative management of the injury will be. Vikas sir will be explaining in detail regarding the management.
Okay, see what happens. Can we go to slide before?
Sir.
Previous slide. So you can see that it is a zone, like it is a avulsion, or you can say from the footprint, you can see that there is no tendon remnant or very few fibers of tendon remnant. So we have to fix this tendon to the bone. If there was a injury was in the on the proximal phalanx, then we have to do repair from tendon to tendon. But here we have to do tendon to the bone. What we do, we first freshen the edges of the bone. That is what we call preparing a footprint where original tendon was there. Remove all the fibrous tissue and everything so that it's a bleeding bone, or you can say you have to scrape the scar tissue away from, so that it is a bleeding bone, it heals properly. So there are many ways of fixing bone and tendon, but thing is something should be attached to the bone, that is a hard tissue, and it should come and attach the central slip, that is a soft tissue. So now you can see this is an anchor. Anchor is that many types of anchors, suture anchors, in which a screw kind of a thing goes into the bone. And the video you can see we are pulling the thread, and bone is or joint is moving. So it is fixed, the thread is fixed into the bone with the help of a screw. Now the tail of the anchor in which we can do the repair of the tendon, take bites. Do we have next slide?
Yes, sir.
So we take the tendon, I think if we can enlarge it, you can see we just, can we go to the next slide?
I think it's
Okay, so we suture the tendon using both filaments. They are loaded with a needle, and suture the tendon back to the bone. When we tighten our knots, the tendon and the bone, they become approximate to each other, and with the healing, with the time it heals properly, and that is what about repair. And post-operatively, depending on how good our repair is, we mobilize the tendon. Usually what we do flexion, we stop the full flexion. We just give a flexion stopping or limiting splint on the volar boards, so that patient can do the extension, but not against the resistance, so that the joint doesn't become stiff and joint is mobilized. Here, the important thing in extensor tendon is that it is very sensitive to the tension. If we over tighten the extensor tendon, because they are connected to each other, the deformity can occur in the adjoining joints. Like if it is very tight, then there can be a lag in the extensor tendon at the DIP joint. So the tension has to be proper and mobilization has to be early, but in a limited way, not the full strength or full range of motion. Any questions till now?
Sir, if there would have been fibrosis, you clean the fibrosis and then
Yeah, we have to.
We
Yeah.
clear out the fibrotic scar tissue and freshen the bone edge also. And
Okay.
we take down all the scar, because sutures will not pass through the scar tissue. It has to come through the native tendon, the pristine tendon stump that we find proximally.
Okay.
Sir, I have a question. Sir, what are the factors that decide the prognosis or the outcome from the surgery?
Okay. The first factor is the duration, because more retracted the tendon is, the alteration in the length will occur, and very difficult to approximate bone and the tendon. So, first thing will be the duration from the injury. Second is because, as Gaurav was talking about, there's a soft tissue is less. So if it is an open injury, skin is scarred, then there is a prognosis is not good. Third, again related to the duration, if joints are stiff, even if we do the good repair, if joint is stiff, we are not going to get the movements. Anything, Akram, you want to add, or Gaurav, you want to add?
I think the crucial part is the chronology of the injury. Earlier, the better. It is always said that the longer we wait before repair, the stiffer the joint will be.
And sir, if there is a complete tear of the tendon, it might get retracted. So it becomes very difficult to approximate
back.
the tendon.
So in such cases, we have to use small grafts, because if we try to do over tightening, then the cut through of the stitches can happen. So that is another topic. We will talk about it later. Can we go to the another second
Yes.
case?
Sure, sir.
Thank you, sir. Thank you.
So talking about our second case, a 55-year-old female, which she got operated for distal radius fracture in 2010 elsewhere, and then recently started experiencing pain and tingling sensations over right wrist with difficulty in extension of right index finger. So on examination, there was mild flexion of the index finger with no active extension of the index finger alone, but there was extension with the other fingers. So patient was sent to the radiology, and these are the X-ray images. Dr. Ira, can you please?
Yes. In the lateral and the oblique X-rays, we could see that there were few screws which are projecting beyond the cortex. In the AP view, we could see that the screws were within the cortex. So for further clarification, we moved on to the ultrasound.
But how can, ma'am, if may I ask, like in the oblique views, we can see the screws are going into the joint. But in the AP view, we can see that all the screws are going well beneath the joint. How is this possible?
So the possibility is that it's maybe penetrating the dorsal cortex and not going into the joint. That can
But
also
they
be a
are,
possibility, because In the AP view, we can clearly see that it's not projecting into the articular.
Exactly, and way beyond the articular surface.
Yeah.
Yeah, so it is definitely not going into the radio carpal joint space, but
Okay.
it may be projecting through the dorsal surface,
Okay, they are going through and through the bone.
dorsal cortex. Yeah.
To
Okay, okay.
dorsal cortex. Okay. Then we did the ultrasound. On ultrasound, we could see that there were few screws which were projecting on the dorsal aspect of the wrist, as seen on the lateral X-rays, and they were projecting into the fourth extensor compartment. In the index finger, we could see that the extensor tendon was seen over the PIP and the DIP joints. We could see the extensor tendon, which was intact in the finger. But the extensor tendon to the index fingers, both the extensor tendons, were seen to be torn at the level of the wrist.
So you can see that this is the screw which is projected through the dorsal cortex, and generally we do see the normal. This is the short axis view, which is, you can say, at axial view, where we should see the tendon in this region. But we are not seeing the tendon. Instead of that, we are seeing this screw, and which is projecting through it. So this is what we saw, and we did a dynamic imaging in the long axis. Can you just go to the previous slide, Dr. Ira? Yeah. So this is the tendon, which is seen this is a different tendon of the fourth compartment. And whereas here, if we see, there is the screw which is projecting through it, and and in the other view, we can see that the tendon has been ruptured by the two screws here. Right.
Okay. And dynamic, do we have dynamics?
Do we have the video, Dr. Ira?
Sir, there was no video saved in PACS.
Okay.
Okay, dynamic, you can make out the tendon moving and the stump moving. So
Yeah,
which
yes.
tendon has this extensor digitorum?
So, sir, when we at this level, when we saw, we were not able to appreciate both the tendons. Like, we thought both the tendons are torn at this level.
Both means
Index
middle finger,
index finger,
index and
so indices and the digitorum.
okay, both were gone.
Yeah.
So okay.
That's just another image showing the same finding. We can move
Okay.
on to the next
So
image.
how did you do this image is transversely taken?
Yes, sir.
Okay.
Did you flex the wrist
So
to take this image?
No, sir. This is just, we have done a normal, just directly we have put on the wrist joint, and we saw this. But while doing the dynamic, what we do, we move the finger according to which tendon we want to see, and then we see whether there is any movement which is happening in the long axis.
okay. Okay. So anything else, or we go for
Yeah,
the
we'll move
next
on.
one?
Move on, sir.
Yeah.
So any
Gaurav,
other
can we-
investigation, sir, Dr. Vikas, sir, can I ask something?
Yeah,
Any
yeah,
other
you can-
investigation, or Dr. Amit would suggest any other investigation that would be more helpful in diagnosing a screw penetration, or maybe MRI can be done, or if not MRI, CT scan can be done or not?
Yes, CT scan can be done, but in order to see this soft tissue, the tendons, I think this ultrasound was enough to say.
Okay.
See, one thing I want to, in the hand, especially tendon, etc., I'm not seeing MRI as a beneficial tool, because all these tendons, they're not very much straight. So reading a MRI, or many times it is very difficult to on the plain MRI just see the for the tendons. I think ultrasound is a modality of choice. What do you
Yes,
say,
I
Amit?
agree. I agree, sir. And the other advantage in ultrasound is the dynamic thing, which is.
So were you able to appreciate a gap between the extensor tendons of the index finger?
Yeah. So we saw that there was a gap, but we couldn't see the too much of retraction which was there. It was just lying nearby, I think. I don't remember exact gap, but yeah, there was a gap.
Okay, now Gaurav, next.
And Vikas, just to add regarding the MRI, what happens like many places the MRI is not done properly. Like the other case which we saw about the glomus tumor, it was very like classically, clinically very much there. But the MRI which was done for the whole hand instead of the thumb. So that is another challenge which we face if it is done in different centers.
Even the contrast MRI could not pick it.
Because it was not done properly, like it was done a large field of view where all the fingers were included, and by the time we see that small thumb tip, at that time it is
It is
all
not focused like to be
Yeah.
like. Okay, so in the slide, Gaurav, will you be presenting or should I?
So, intraoperatively, it was seen that the screw was definitely poking onto the dorsal surface of the, it was coming out of the dorsal surface of the radius, and it has torn the EIP tendon specifically, but has spared the EDC. The EIP over the wrist is like placed over the ulnar aspect of the EDC of the index finger, as we may confuse it like being on the radial side, but mostly it is present over the ulnar side of the EDC of the index finger. So what we did was, we can appreciate the screw over here and the torn tendon of the EIP. So what we did was the EIP repair was done and the partial implant removal was done. Sir can let us know in detail about it.
Yeah, because see, this is a locking plate and the screws were jammed proximally. So we removed the offending screws and plate was because plate is on the volar aspect. So to remove that plate, we have to cut the screws and this thing. So partial implant removal, that is offending screws were removed. Can we have interop slide again? Interop previous slide. See what happens whenever there's a attrition from the you can say fracture end or the implant. It is not a single cut. It is a
Attritional tear.
segment. It is a segment because of attrition. It is a whole segment is gone. So doing an end-to-end repair is not possible because that ends are not well enough and they are like because of attrition they're very irregular and very unhealthy, and you can say a lot of scarring is there. So in such cases, either we do a tendon transfer or do the tendon grafting. In this case, another thing, EIP, the easy way to identify EIP is that you can see the muscle belly up to the wrist. So very difficult to sometimes ulnar radial. When you see a muscle belly, that tendon is EIP tendon. Because muscle belly in the EDC, they will end in the distal forearm, but EIP, it comes up to the wrist.
Right, sir.
So what was done in this case, Gaurav?
Sir, I was not there at that time, but the
Notes,
records are just suggesting that the repair was done. It was not written whether it was reconstructed using the
okay.
graft.
No. That is where discussion was. So doing a grafting because it is a long segment, it is not advisable. What happens when there's a long segment involved? You try to take a graft has to heal at two places.
Right,
And that
sir.
segment which is there, it is a avascular. And especially in extensor tendon, what we do a end-to side repair. Intact tendon is taken, which is the adjacent tendon, and we suture the injured tendon to the intact tendon because normally in the anatomy also these extensor tendons they are connected to each other. So that is why we did an end-to side without putting in a graft. So repair was done. End-to-end repair we don't do. End-to side like middle finger intact tendon was stitched to EDC of the index finger.
Or if the EDC of the index finger intact, then we can use that also.
No, if sorry, EDC
If
of
the
a
index is
if EDC index finger, then you don't have any problem.
We
Because
don't
then it
have
is
to.
acting. We don't have any problem. It is when both
Both the tendons are
tendons
gone.
of index finger are gone, then only you'll have deformity. Otherwise, one tendon is good enough to move the index finger.
Right, sir.
Anyone.
Okay. So in this case, one tendon was intact, but still I remember there was extensor lag.
No. Both tendons, EDC, index finger, and EIP was gone. That is why there was a finger drop.
Okay, so
And
both were torn, right?
if I remember correctly, this surgery was done, I think, 10 years or something like that.
Sir,
Yes.
the type of plate that was used also, it's not so commonly used these days. It must be a decade back that we used to use these plates.
Yeah,
Yeah, 2010. 15 years ago, surgery was done.
So one quick question. So many times we see that the screws, they project across the, like, through the cortex of the bone, but they don't cause any tear or anything. Even we have seen in the forearm plates also. So why do like some get torn and some don't?
Okay, it usually this happens at the wrist level, because at the wrist level tendons are in close proximity to the bone, and they're going through the compartments. Compartments are just like a tunnel because the extensor retinaculum. So it is in a very close proximity to the bone. So anything projecting through the bone, not only screw, even if fragment is there, it will cause adhesion and late ruptures. As in this case, you will see that it is 15 years or more than a decade old surgery which led to this kind of a problem. Even we've seen that non-operated cases of distal radius, they also can have a extensor tendon injury, because one sharp fragment which keeps on rubbing and causes the injury.
Okay. So once the fracture has been united, to prevent
In
this.
forearm, it is not a compartment. So what happens, even if you do the plating, dorsal plating, because retinaculum is not pressing the tendons against the bone, so chances of adhesions are less. But at the wrist level, because of the tight compartments, close proximity, the injuries are more.
Okay.
Such injuries are more.
So in this case, in order to prevent the soft tissue injury, the plate could have been removed previously because this complete union has happened.
Yeah, patient was advised. Actually, patient was.
Okay.
Sir, I have a question. Is it possible to that any screw which is projecting from the cortex and lying subjacent to the tendon, and patient complaining of the pain in that region and in the
It is always that
fing-
there will be synovitis pain, but patient ignores it, then only injury will occur. It occurs over a period of months. It doesn't occur overnight. The tendon is becoming slowly weaker. There is a lag, and then suddenly one day it breaks. So if patient is complaining of pain, then we must take it seriously and get it investigated.
Okay. You can move on to the next one.
Sure, sir. Now we'll move on to the third case. It is one of the most common extensor tendon injury which we are seeing nowadays. For example, this one, the 19-year-old male, pain and swelling over the right index finger with the difficulty in movement over the DIP joint. The history of blunt trauma with cricket ball while playing cricket, and it's a 2.5 months back injury. And on examination, there was flexion of the index finger at DIP with no active extension. So this was the X-ray. Dr. Ira will explain to us.
Okay, so I'll take this one. This Dr. Sydney.
Yeah.
So this is the lateral view of the index finger, and it shows a bony avulsion about 3 mm from the dorsal aspect of the base of the distal phalanx. And then the gap between the avulsed bone and its previous attachment is about 2.5 mm. The rest of the bone was fine, and the overlying soft tissue edema was also seen. So based on the side of the avulsion, it's possible it is the terminal slip attachment. Next slide, please.
As we can, Dr. Sydney, as we can also see that the finger is going into some sort of
Yes, there's a
deformity.
flexion deformity. Yeah.
Yes, and
Flexion
also a
deformity of the
hyperextension
distal.
at the PIP joint. We can appreciate that also on the lateral view.
Okay, yeah, it's true.
So
Yeah.
this
So
is a
flexion deformity of the distal and then
Yeah.
the PIP joint to there is
so
here.
this is a swan neck kind of a deformity. So it occurs whenever it is a long-standing injury at the terminal slip. Yeah, you can continue.
Yeah. So next slide, ultrasound was also done. It was demonstrated, the avos bone was demonstrated, movement with dynamic ultrasound shows the gap movement, and then surrounding soft tissues was also seen as demonstrated.
So this is the image which has been taken in a neutral position. And this is the kinematic image where there is a flexion done and you can see the bone fragment. So there's an increased gap between this, and to this bone fragment is attached the terminal slip. So this is how the advantage of doing a dynamic or a kinematic imaging helps us. So
Sir,
yeah.
one question, like you can see both the views through single probe only, like
Yeah, so we will change the orientation of the probe. So what is like, we have kept the probe in the long axis like this on the DIP joint, and here also this image is again the long axis view where we have kept the probe here and in the same plane, but we have done the flexion of the DIP joint.
Right, sir. Because we can see the bone in the lower two images in two different.
So
views.
no, so this is again the same like this image, and
The upper one, yes.
this is the like we have kept the probe here, and the finger is in the
This
sort
is the axial.
axial image. Yeah.
Okay, sir.
Dr. Amit,
Yes, sir.
we could see a fragment. There is a dorsal fragment on the distal phalanx. And
Yeah.
we could see that there is joint flexion. What additional information that we get from the ultrasound now?
So will see whether the fragment is completely separated from the parent bone or not. This is the first thing about the size of the bone fragment, and whether the whole of the terminal slip is attached to the bone fragment, or there are some the fibers which are also torn at the bony attachment. So these all informations we can see. Along with that, the ligament injury, volar plate, and everything else.
Okay.
So we can go to the next slide, Dr.
So on the basis of the clinical examination and the radiological studies, the zone 1 extensor tendon injury with bony mallet deformity diagnosis was made. Sir will explain the bone procedure done for this same.
Okay, this is a procedure is modified Ishiguro technique. It's a simple procedure where we don't give any incision. First, we take a first wire, we flex the DIP joint, and we go proximal to the fragment, because we know that bony fragment is attached to the tendon. So we go proximal to the fragment, put a wire into the middle phalanx without going through the joint, just trapping the K wire fragment in the K wire. And when we extend, what happens when you extend the DIP joint, then there'll be like, because fragment is already trapped with the K wire or buttressed with the K wire, and you extend and stabilize the DIP joint. So it brings the both fragments together, putting it back into the place. And when healing occurs, we just remove the wire at 3 to 4 weeks, and fracture heals, because tendon is attached to that fragment. Once fragment heals, the tendon also heals. Next
Okay,
slide.
so in this case,
Patients-
like what happens in many times, if we do a follow-up X-ray, it is very difficult to say whether the avulsed fragment is completely united or not. So it is up to your clinical decision. You decide that when to remove the K-wire.
Radiological, okay, 4 weeks is a good enough time unless there's a lot of gap or something. As you know, on X-rays, the union occurs later because first it heals and there's a soft callus which is not calcified. So you will see maybe 6 weeks, 8 weeks, you'll see the complete union. But if we keep the wires till that time, we'll have a joint which is very stiff, or the even bone can grow and becomes a like fibrosis and like just like a fusion.
Okay, okay, so we don't need a CT in this case, right? But
We don't
No,
know.
it will be more of academic exercise. Most of the time, even after removal of the wire, we give a splint.
Okay.
Splint, which is keeping the DAP joint into hyperextension, a stack splint kind of a thing. Because we cannot wait for more than a month or so, joint will become very stiff. Akram, you were saying something, sorry,
I was saying this only, that we don't wait for the healing to be documented. Actually, we believe that healing must have occurred, and we still protect the finger in a splint, and we start intermittent mobilization only.
Okay, okay.
And sir, at times, like whenever there is only the tendon which is avulsed in zone 1 injuries, we sort of send the patient again to ultrasound like at 6 weeks or something. Akram sir, we did a few times. Like
Yeah.
what are we looking for at that time?
See, at that place, at the terminal, this thing, when it is a only soft tissue mallet, that
Yes, sir.
means there's no bony fragment involved. Then we know we give a splint in extension, so we know that there is going to be a fibrosis because extensor tendon, they don't retract like a flexor tendon because of lot of attachment, lateral bands and other things.
Right,
And
sir.
when you do a hyperextension splint, like a stack splint, there's going to be a scarring and fibrosis, and it heals properly.
And how does we
So in
differentiate that?
ultrasound, we just document that there is a continuity of fibers with the bone.
Okay.
Amit sir?
Yeah.
How we document like whether it is the tendon which has healed and oriented properly?
Yeah,
The
so we have done a couple of one, like we are recently, I think we are still following one of the lady with that.
yes.
So what happens, like we compare with the previous imaging and we see that
Mm-hmm.
gradually the fibrosis has increased. And in the last case, which I'm talking of, so in that initially there was a gap. And as we did the follow-up ultrasounds, we saw that the gap decreased and there was fibrosis, which was continuous with the bone, which started forming. And so we can say that, okay, healing is happening.
So on ultrasound also the
Yeah, ultrasound only.
car will show as a gap only.
No,
Initial.
initially there was a complete tear in that case, what I remember, and then gradually the gap decreased because the fibrosis started happening,
Right, sir.
and later on the fibrosis increased, and there was a continuity between the torn fiber and the bone, and that gap was filled by the scar.
And the collagen deposition pattern also changes with time.
Yeah, that definitely changes. It won't look like a normal tendon. There will be like heterogeneity.
But with time it will improve.
Yeah,
From
with time it improves, but I am not sure whether it will look like a parent normal tendon or not. I don't think so because there is the fibrosis.
because at times these soft tissue mallets they tend to have some sort of like 10 to 20 degrees of
Deformity.
extension.
Yeah, right. But by that time we see in the ultrasound that there is a complete filling of the gap by fibrosis.
So Vikas sir, one question, like the extension lag may be present even after complete healing of the soft tissue mallets.
That is a scar tissue. That is what we were talking about at the PIP joint. That
Right, sir.
scar tissue is if we are prematurely mobilizing it, removing
It
the
lengthens it.
splint, it can, before maturation, it becomes lengthen. So that is why splint has to be used for 23 hours a day for at least 6 weeks.
Okay, at
Many
least 6 weeks,
times-
and then we move on to the 2 weeks of night splinting.
Yeah, because even if you're removing the splint every day and this thing, then tissue will lengthen and there will be a lag.
And then
and
what we
many
studied,
times
like
when-
5 mm lag will lead to 10 degrees and all those things.
Yeah, so
No, 1
so
mm gap will lead to a 25-degree deformity.
Sorry, 0.5 mm. Sorry. 0.5 mm to 10 degrees and 1 mm to 25 degrees. Right, sir? Yeah, 5 mm is a way too big deformity.
So, next slide. Is there anything else in this case?
No, sir.
Anyone-
Now we'll move on to the last case for
Anyone wants
tonight.
to discuss the previous case, mallet finger? Any questions?
So the mallet finger is zone 1 injury. So the central slip injury is what, zone 2, because it's at
3.
the
Zone
Three.
3.
It is at the PIP joint. Central slip injury is at the PIP joint. Mallet finger is at the DIP joint. So there are entirely different zones of injuries.
okay.
Ma'am, zones are over the joints, odd numbers 1, 3, 5, 7.
Thank you.
Right.
I think we can move.
So moving on towards the last case for tonight, 25-year-old female came with the inability to extend right thumb and deformity of the right ring and little finger, with difficulty in movements. There was a history of injury to the right hand while with the involvement of right ring finger, and she developed pain and difficulty in the movement. She's a known case of JRA, and on examination there was flexion of the thumb IP joint with no active extension, and also boutonniere deformity was seen over the right ring finger and little finger. So these were the clinical photographs of the patient, in which we can clearly see the drop thumb at IP joint, and also we can appreciate the hyperextension at MCP joint of the little finger and ring finger, with the flexion at PIP joint over the two fingers. So now we'll discuss the imaging. Dr. Sydney, will you be?
So X-ray bilateral wrist AP view shows bilateral generalized reduced bone density, bilateral symmetrical reduced joint space, and ankylosis of the intercarpal, carpal, metacarpal, and the radiocarpal joints, as shown by the in the wrist with a blue arrow. There were also areas of erosions or subchondral cysts at the base of the left first metacarpal white arrow. Then ankylosis and erosions or periarticular osteopenia also seen generalized, also seen in the bilateral second metacarpophalangeal joint and left third metacarpophalangeal joint, as indicated with the black arrow. There was also reduced joint space seen in the right first metacarpophalangeal joint, yellow arrow, and then the flexor flexion deformity seen in the ring finger, and then the little finger, fourth finger and fifth fingers were also seen at the proximal interphalangeal joint. So the signs of the area was there, plus these deformities as indicated. Next slide.
Can you please explain the term ankylosis in the form of X-rays?
So in ankylosis, there is severe reduction in joint spaces, and then you don't see, I don't have an eye, but you don't see on the wrist, you can't see the joints, the intercarpal joints at all. So in ankylosis, there's like fusion of the joint spaces, yes.
So basically the joint fusion only you are referring to, na?
Yes.
Okay.
So this is the same in different views, same findings. Next slide. And then during ultrasound, the flexion deformity was demonstrated at the proximal interphalangeal joint of the fourth and fifth fingers on the left, with thinning of the extensor, common extensor tendon of the fourth digit, with subluxation of the lateral slips. And then ultrasound of the thumb. Next slide. Ultrasound at the time also shows a complete chronic tear of the extensor pollicis longus tendon at the level of the carpal metacarpal joint, with retraction of the proximal end of the tendon beyond the distal tubercle. The distal tendon was also seen and shows diffuse thinning. The flexor aspect of the thumb was normal. So those were the findings that were seen.
So this is the region where we are not able to see the extensor pollicis longus, and whereas distally we can see this tendon, though it is not looking normal. There is, I think, some retraction, some fibrosis which has happened, and similarly this tendon is all thinned out, and there is this all synovium which is thickened, and maybe there is also ankylosis in this region as seen in the X-ray. Right?
Yeah. So next slide, like any questions still for radiology?
I think we can move on.
Move to the next slide. Yeah.
So in this patient, we, as sir, like in the previous patient, Vikas sir said, whenever there is attrition rupture or chronic ruptures of the tendons, the ends of the tendons are not, they cannot be used for simple repairs, and even the reconstruction becomes very difficult for those kind of tendons because they are weakened up to a great length. As Dr. Sidney also told us that there was retraction till the Lister's tubercle, and even the distal part of the tendon was very thinned out. So the EPL reconstruction was done with the help of tendon transfer, that was EIP to EPL transfer, plus the deformity correction of the ring and little finger of the right hand was done. So Vikas sir will talk about the tendon transfer for this patient.
So what happens, as we said, putting in a graft, the transfer becomes easier option because index finger has two tendons and both are good tendons. So what we do, we take a EIP because EIP is an independent unit with a separate muscle and a separate tendon. As compared to the EDC, they are connected to each other. So identify the EIP. EIP is when it is at the MCP joint, it is on the ulnar aspect. When you open, you see two tendons. The ulnar one is EIP, and we open the up to the wrist, going proximal to the compartments, fourth compartment, and cut the EIP and take it out, or you can say deliver in the distal forearm beyond the wrist, because we cannot take the tendon and cut the tendon and put it to thumb. Then there will be a very big angle there, which will cause decreased movement and the vectors won't be good enough. So you deliver your EIP, the proximal part of the EIP into the forearm, and you deliver the EPL into the base of the on the metacarpal. So both ends are there. Do we have a next slide? Showing the in this slide also. Okay. Now you can see that that is a EIP which is coming from above, and from the thumb, the EPL, the cut end of the EPL, you can see very thinned out EPL that injured, and this is a healthy EIP. You can even see the color difference between the healthy and the unhealthy tendon. So shiny tendon is a healthy. So we route the tendon in the subcutaneous plane, because if we are going to not take it, if we don't deliver from the compartment, then there will be a long angle and excursion will be decreased. And we do the very good repair, as you can see in this, that multiple sutures are used over the long segment. Why we do this? Because we want it to move next day. as a so it's this is completely different from the flexor tendons where we use single knot
Sir,
or double.
yesterday you were
knot.
talking about this only, na? When I asked
Yeah,
you
yeah,
about the early
yeah.
mobilization.
So multiple tendon, multiple sutures, because this tendon is in the subcutaneous plane. It is not in the fibroosseous canal as it is in the flexor tendons. So this robust repair is done so that we can mobilize them early. That is how it is different from the flexor tendon, because flexor tendon, if we do such kind of a repair, then it will get stuck. It will become a trigger finger or stenosine tenosynovitis, because flexor tendon has to go through a tunnel, fibroosseous tunnel, pulleys. And this one is going in the subcutaneous plane where we want the strength and mobilize them early.
Okay.
Next slide. Do we have any other slide? No.
Yes, sir. In this, we were having the botanier deformity also, no?
So in Butner deformity, Butner correction, okay, this is after the repair. You can see how do we check for the tension. We check for the tension when we flex the wrist, the IP joint should be extended. And if we flex the wrist, IP joint should go into 30 degrees of flexion at least. So we don't over tighten or we don't keep it lax. Because in anesthesia, anesthetized patient, this is very important to measure the tension. So we take first stitch where this thing, and we see whether our tension is good by flexing the wrist, inflection or extension. We see the movement at the IP joint, passive movement at the IP joint. Other things, okay, patient wanted the cosmetic correction of this deformity also, and because it was a long standing, so it was volar sided lateral bends were brought together on the center on the dorsum so that they act as a dorsal force, and they were repaired. Central slip was repaired, and KOA was put to splint the PIP joint, because this is a long-standing injury. So we put up temporary KOIs for 3 weeks or so the tendon can heal, because there's a very excessive tension in the soft tissues in the opposite direction. So if we don't immobilize with the help of K-wire, then there might be a cutout or failure of the repair. So these wires are temporarily, we remove the wires. After 4 weeks or so, we get intermittent movements with the splinting, intermittent mobilization of PIP joint is done.
Okay, sir.
Questions? This is the last slide, or Gaurav, any more slides?
Sir,
This is the post-operative
this is the last slide.
Yeah.
Another question, please. So, if I understand the procedure, you cut off the extensor indices and then redirected it to the thumb.
EPL, yeah.
Afterwards, is there any limited movement in the
No,
index
it's a
finger?
complete movement. It's a complete, no limitation. As I said, one tendon is good enough. That is why I said one tendon is good enough. If only EDC is cut or even EIP is cut, only one of them is cut, we don't do anything.
And in terms of just probably giving instruction, normal instruction that goes to the index finger, now that tendon has gone to the thumb. Is there any confusion in hand movement?
No, the patient sees it. It is a patient, when patient sees it, starts mobilizing, so brain relearns and does the normal function.
Okay.
Okay, sir.
Suppose there is a this ankylosis or pseudoankylosis at this interphalangeal joint of the thumb. So, would you really go for the repair?
No, if there's a bone, if passive movements are not there, then I'll not go for the tendon repair. Then we'll just do the fusion in the
Functional position.
appropriate position or functional position.
Okay,
Okay.
sir.
Okay. Thank you, everyone. So
Any questions? Otherwise, we just say good night. Any questions from fellows? Akram, any question?
Hello?
yes, sir, you want
Akram,
to
any
add?
question?
Akram, sir, you want to say anything?
So we say goodbye. Okay, it was nice. So next time we'll be talking about flexor tendons
Sure, sir.
and related topics like chronic and acute, and what we do when it is a pulley reconstruction and other things. So next time we are going on the volar side of the hand.
Thank you, sir.
Right,
Thank you,
sir.
everyone.
Thank
Thank you so
Thank
much,
you,
sir.
sir.
Thank you,
It
sir.
was very
Good night.
Good
Good night. Good
good,
night.
sir. Thank you
Thank
so
you,
much, sir.
sir.
Good night.
Good night, everyone.